Hello and welcome to ECGs for Students. My name is Dr. Sebastian Gracias. I'm a cardiology intern at the University Hospital Galway and a graduate of the Royal College of Surgeons in Ireland. The ECG is a cost-effective and portable test that detects cardiac electrical activity. It's not only useful, but frequently tested on exams, although it's oftentimes poorly understood by students. For this reason, I designed and delivered an ECG tutorial for students in my last 3 years of medical school. Today I'm making that same content available as an open access e-learning tool. During this tutorial, you will learn how an ECG machine works, then what a normal ECG looks like, and we'll finish up with ECG findings in common cardiac diseases. These learning outcomes will prepare you for your exams at the level of a final year student. Review them at the end to ensure you understand each topic. Let's get started. An ECG uses electrodes placed on a patient's skin to gain electrical readings of the heart. Let's look at a single electrode on screen right to see how this happens. Imagine current flowing towards the electrode and perpendicular to it. This results in a net, large, positive deflection. If current flows towards the electrode at an angle, we get a positive but weaker deflection, as some of the current's energy is wasted as a vector in the plane parallel to the electrode. Conversely, if current flows away from the electrode in the perpendicular plane, we get a large negative deflection, with a weaker negative deflection if the current is at an angle. Lastly, if current flows entirely in the plane parallel to the electrode, we get no deflection or a biphasic wave. Although the ECG is an electrical test, it's useful to think of the heart in radiological planes. The limb leads, for example, give us a coronal picture of the heart. I will now draw out each of the limb leads according to my rule of 30. Familiarize yourself with this diagram, which is vital for your exams to remind you of the relationship between the overall cardiac vector and individual limb leads. It's very simple. We draw a simple T shape and label each line sequentially. Starting on the left, the first line is lead 1. The second line pointing down towards the patient's feet is AVF, F for feet, and the third line is imaginary. We then pencil in all the other leads in 30-degree intervals to the lines we've already drawn. 30 degrees from lead 1 on patient left is AVL, L for left. 30 degrees on patient right, 30 degrees away from the imaginary line is AVR, R for right, and 30 degrees on either side of AVF are leads 2 and 3, with 2 being closer to lead 1. We can also group the leads together systematically. Leads 1 and AVL are lateral on patient left and are therefore called the lateral leads. Pointing downwards, 2, 3 and AVF are the inferior leads. Now, although the heart experiences conduction in many different directions, it's possible to add all of this together to get an overall vector of flow. The size and direction of this vector depends on cardiac muscle mass. The left ventricle is thicker than the right, which makes sense because it pumps blood all over the body, while the right ventricle pumps blood a relatively shorter distance to the lungs. It makes sense, therefore, that the overall cardiac vector is left-leaning. Although textbooks say that the normal cardiac vector lies in a range, let's assume for the sake of simplicity that it's in the same direction as lead 2, now highlighted in red. Similar principles apply in the axial plane. The chest leads are placed on the anterior chest wall, with V1 to V3 overlying the right ventricle and telling us about the left anterior descending artery. They're placed anteromedially and are therefore called the anterior chest leads V1 to V3. V4 to V6, on the other hand, are more lateral and overlie the left ventricle, giving us information as well about the left circumflex artery. The overall cardiac vector in this plane is also left-leaning. Let's assume towards V5. Our first ECG has a normal axis, and by splitting the ECG into its constituent parts, we can further analyze the axis. On the left, the limb leads and the diagram from earlier show us that the overall cardiac vector is aligned with lead 2, so lead 2 is most positive. The next closest lead is AVF, which is the next most positive, and the next closest leads after that are leads 3 and leads 1, which are equidistant from lead 2 and are therefore the next most positive and equally positive when compared with each other. AVR is completely opposite to the overall vector and is therefore negative. The chest leads on the right of the screen, together with the diagram from earlier, give us a better picture of V1 to V6. Since the overall cardiac vector is left-leaning, V4 to V6 is positive, while V1 to V3 is negative. As we move from V1 to V3 and then V4 to V6, we also see a gradual change in terms of negative deflection to positive deflection as we approximate the overall cardiac vector. At the bottom of the screen is the rhythm strip generated from 10 seconds of lead 2. To calculate the heart rate, simply multiply the number of QRS complexes, seen here in 10 seconds, by 6 to get the number of heartbeats in 60 seconds. Our next ECG shows us left axis deviation, which can be caused by a thicker left ventricle, say in left ventricular hypertrophy, or a thinner right ventricle, say in right ventricular infarction. If we split up our ECG into constituent parts, the limb leads now on the left show us that the axis has shifted to the left-hand side, pointing away from lead 2. So lead 2 is negative. The axis is closest to AVL, second closest to lead 1, and third closest to AVR. So AVL is the most positive, then lead 1, and then AVR. The axis is away from the inferior leads, so these are all negative. Next, we have the chest leads. In a normal heart, the axis is left-leaning, so V4 to V6 are positive and V1 to V3 are negative. In this case, the left axis has shifted further left, so V4 to V6 are more positive and V1 to V3 are more negative. In other words, a left axis deviation basically changes the left-leaning axis of the heart and makes it more strong, therefore accentuating the pattern we already see in the chest leads. Lastly, at the bottom, we have the rhythm strip, which is again 10 seconds of lead 2. Our last ECG depicts right axis deviation, which can be caused by, say for example, a thicker right ventricle in right ventricular hypertrophy, or a thinner left ventricle in left ventricular infarct. We split up our ECG. On the left, the limb leads now show us that the axis is shifted from lead 2 towards the right. But it's still in range to cause a positive deflection lead 2, although lead 3 is more positive as the overall axis is now closer to lead 3. The axis is away from the lateral leads, so these are unsurprisingly net negative. If we examine the chest leads, the axis is shifted towards the right, causing a positive deflection in V1 to V3, and although V4 to V6 are still positive because the overall vector is in range, these are less positive than we would expect when normally comparing V4 to V6 with V1 to V3. In other words, the axis has reversed in the axial plane, so we see a reversal of the normal pattern in the chest leads. This ECG has no rhythm strip. This concludes part 1 of ECGs for students. Please look into the description below for contact details if you have any questions and our social media page. You will also find a link for part 2 of ECGs for students. Thank you for watching.